So today we're talking about a recent case that was referred to me of a 21-year-old college student who presented to me with a primary complaint of back pain. Now, back pain is probably one of the most common sources of referrals from primary care physicians to begin with. So in a 21-year-old, back pain on its own may not be unusual, but in this case what was unusual was that the pain appeared to be refractory to conservative measures and did not appear to get better at all. So an MRI was performed that's shown over here, and that shows this mass located within the base of the spinal canal, kind of at the L5 and S1 level, which shows enhancement or uptake of contrast when contrast was added to the MRI. So this appears to be a type of spinal tumor, and spinal cord tumors are classified in three different categories, and it's based on a location of where it's located within the canal itself. The most common type of extradural extramedullary tumors, those are tumors that are located outside of the dura, are drop metastases. Obviously, these are pretty rare in a 21-year-old who's otherwise healthy. Otherwise, you have tumors that are within the dura itself, or what are called intradural tumors. And these can be classified as intradural intramedullary, which are tumors that are located within the spinal cord themselves, or intradural extramedullary, which are tumors such as meningiomas and schwannomas that arise from the covering of the spinal cord and the nerves themselves. Intramedullary tumors, used by contrast, are tumors that start within the canal or nerve parenchyma themselves, such as ependymomas, astrocytomas, other type of tumors that tend to form from the nerves themselves. So once we have this information, obviously knowing that the size of the tumor and the fact that it's clearly causing mass effect or compression of the nerves, the treatment for this is almost always going to be surgical resection, especially in a patient this age. So the way we do this, especially in a young patient, is to do whatever we can to avoid fusing. And fortunately, this tumor appeared to be primarily within the midline. So we did a midline laminectomy with doing my best to remove less than 1/3 of the facet joint. This prevents the development of iatrogenic or physician-caused instability down the road. Identifying these types of tumors, particularly at the base of the spine, the primary area for safe resection is identifying the filum terminale, which is a part that tethers the spinal cord down through the nerve roots. The filum can usually be safely taken, but we usually stimulate this at the time of surgery, as you can see in this picture here. And once we identify that there's no traversing nerves, we can take it, and that tends to retract the tumor upwards. That allows its safe dissection. So this tumor was dissected away nicely. As you can see in the postoperative MRI, the tumor appears to be completely gone, and the final pathology here came back with a myxopapillary ependymoma, which is a fairly common type of ependymoma that's seen as an intradural mass in a patient this age, particularly in this type of location.